I think we will all get started now with the second half of our Introduction to Analysis presentation. I hope everybody had a really good lunch. I really hope you're looking forward to our SIR dessert that we have coming for you. All right. We're all settled down now. Okay. So with this second half, we're really just going to jump into some examples. We don't really need to speak so much about the technical details of NHSN analysis and the functionality. So we're going to break up this talk about SIRs for device-associated infections into two different examples. And this first one says that given the continued use of SIRs by federal and state agencies, you've been asked to provide a brief SIR refresher training to your committee, okay? So let's go ahead and do that. So I'm going to walk you through some of the basics, and then we'll kind of summarize this into maybe 2 or 3 bullet points that you could use for a refresher about the SIR in general. So the SIR is a standardized infection ratio. We've been using it at CDC since I think about 2010. We started with CLABSI data and SSI data. We now use it for counties and for LabID events for specific types of those LabID events. It is a summary measure that is used to compare the HAI experience among one or more groups of patients to that of a standard population. And we consider the standard population to be NHSN in this case. It is an indirect standardization method, and it accounts for differences in incidence of HAI within groups. What's that getting at is that it is a risk-adjusted measure, okay? So it's not assuming that all patients are the same in all your different locations when we talk about counties, okay? It is going to be risk adjusted. And as you are more than likely aware, at least for acute care hospitals, it is used in the public reporting by CDC for state and national levels. So we have that state and national level report that comes out every year. We're now calling it an HAI progress report. And it's used by CMS for hospital compare. Currently for CMS reporting, that is limited to acute care hospitals, and we are working on SIRs for LTACs and IRFs at this moment. We've started the analysis. I do want to point out, while these are available for CLABSI, for county, for SSI, the LabID is limited to MRSA bacteremia and CDI for facility-wide inpatient surveillance only, and we'll talk about that a little bit more tomorrow and why it's limited to that. So the standardized infection ratio, the basic calculation of this is we take the number of observed HAIs and divide that by the number of expected HAIs. You could use the term predicted instead of expected. Expected is really meant to be a term that represents statistical prediction, okay? And sometimes it's easier to communicate the SIR when you say, how many did we observe versus how many were predicted for us rather than how many we expected. Because if you say expected, the response can often be, why would we expect patients to get infections, right? So using the term predicted just basically says, nationally, when we look at national data and they look at our experience, they would predict that we would have this many, but how many did we actually have? But the calculation of those number predicted or expected, it can differ depending on the measure. And so today we're going to focus on how we would calculate the number of predicted infections specific to device-associated infections, and we'll cover the others tomorrow. So consider this a warm-up because this one looks really easy compared to what we're going to do tomorrow. So for CLABSI and county SIRs, we calculate the number of expected by taking the number of device days that you identified for a given time period and a location, and we multiply that by the NHSN pooled mean, which is then divided by 1,000, okay? We take the pooled mean from a defined baseline report. I have the reports listed here that are used for the baseline for CLABSI and county. what I want to really point out here, we get this question a lot. So even though we update our pooled means every year for rate comparisons, we do not update the baseline data that are used for the SIR. We keep the static baseline data that are on this slide for the time being. And part of this is due to alignment with the HHS Action Plan to Prevent HAIs, which is looking at certain goals for reduction in HAIs through 2013. So now that 2013 is done, we're awaiting the time when most data entry will be done, which is typically about 6 months after the calendar year. And then we can start to produce these SIRs for 2013 and actually measure since 2008, how much reduction in CLABSI have we seen? Since 2009, how much reduction in CAUTI have we seen? We are planning to update the baseline data, so don't worry, we're not going to be stuck in here forever, but we do ask that you're patient with us. We had the question earlier this morning with Kathy. We're changing these definitions, so how can we trend over time? And that's certainly a concern. So what we're trying to do is align new baseline data not only with the new goals that are going to be set forth by HHS, but also to align with the changes in definitions and wait until we have a full year's worth of data where everything's kind of settled down, and then we can begin to analyze and determine how we're going to handle updates to SIRs. So just to demonstrate a little bit of the expected number of CAUTIs, this is a screenshot of a burn ICU pooled mean rate from the baseline data for CAUTI. So that's 2009 data. So we read the pooled mean of 4.4, as we now know, as we discussed this morning. That's 4.4 CAUTIs per 1,000 urinary catheter days. And then we use this for the baseline for the SIR. So we can interpret this as saying, we predict that for every 1,000 catheter days, we will see 4.4 infections if things are the same as they were in 2009. So if nothing changed, we would expect 4.4 per 1,000 catheter days. So, this morning I mentioned that we're going to be talking about methods and about calculations. NHSN does this for you, so don't worry about having to go through and calculate things on your own, but I do want to help you understand what happens behind the scenes. So again, number expected, we take the number of device days and multiply the NHSN pooled mean, which has been divided by 1,000. So if we look at our medical ICU in that first row, we would take 3,284 urinary catheter days and multiply that by the pooled mean for that location divided by 1,000. So we get 7.55 expected CAUTIs in the medical ICU for that location. Now, although we have the total number of CAUTIs, 24 for all these 4 locations, and we actually have a total number of urinary catheter days, we're not going to calculate an overall rate. So this is what I want to try and explain here is how this SIR is actually a risk-adjusted measure, even though you're going to end up with one number. So we don't want to calculate that overall rate. Notice we don't have an overall NHSN pooled mean. We have one per location. So what we end up doing is, in order to get an overall SIR for these 4 CAUTIs, we take the number of infections, the total number, which is 24, and we add up all the number of expected for all 4 locations, which is 24.96. And then the overall SIR is calculated by taking the total number of infections divided by the total number expected. So 24 over 24.96, which gives us the SIR of 0.962. So the overall SIR is not the sum of all of the individual SIRs. It's instead taking the sum of the observed divided by the sum of the expected. And the little table at the very bottom is the output you would get from NHSN for an overall SIR for these locations. So we do that work for you. So, you know, all this I just want to add, and I think I'll touch on it a little bit later too, is that we often refer to the SIR as a scalable measure, okay? Because really what we're doing all the calculations at the location level first. So we've scaled this up to get an overall for these 4 ICUs, but I could just as easily say, well, I only want an SIR for my medical ICU and my surgical ICU. I only want to include those 2 locations. And you could do that by adding the infection count for those 2 and adding the number of expected and calculating the SIR as appropriate, okay? So this is kind of what we do at the national level as well. When we're putting out a national SIR, we calculate the number expected, the number observed for every single location reporting data from all the hospitals, and then we sum it all together to get a national number. So as its name implies, the SIR is a ratio. So if the SIR is greater than 1, then we take that as saying we have observed more infections, or we reported more infections than what we would expect given the baseline experience. So if we have an SIR of 1.25, that means we have 25% more infections than expected or predicted. If we take that on the flip side, if we have an SIR less than 1, then we have fewer infections than reported, right? So that's good. We want to get those SIRs under 1. And so if we had an SIR of 0.5, we would interpret that as 50% fewer infections than expected. So you may have caught that in that table I provided, the snapshot from NHSN, that in addition to the SIR, we also provide a P-value and a 95% confidence interval. Now, a confidence interval can be a little bit difficult to wrap your head around. It can often be difficult for me to try to explain it. So we're going to do our best here. But really what it gets at is it's another test that is being performed in order for you to be able to determine if what you're seeing is a statistical significant difference. So really, we can define this as a 95% confidence interval is an interval for which we have a high degree of confidence that it contains the true SIR, okay? So really, I think what we're saying here is your SIR is actually, it's an estimate. And this confidence interval is looking to see, you know, are we sure that this interval of numbers will have the true SIR, the actual SIR? So there is an upper and there is a lower limit, and we use the values of these to determine the significance and accuracy or precision of the SIR. So if the confidence interval includes the value of 1, then the SIR is not significant. Well, there's many ways to say this, so I'm going to try and frame this in a couple of different other ways. If the lower bound of a confidence interval, so you have 2 numbers, right? You have a lower bound and you have an upper bound. If the lower bound is less than or equal to 1, and the upper bound is greater than or equal to 1, then the SIR is not significant. So what I've done here is I've kind of drawn it out for you to see. So pretend that each of these lines is connecting a lower bound in the confidence interval to the upper bound of the confidence interval. The black boxes represent the SIR. And we get this question a lot too, actually. A confidence interval is always, your SIR, your facility's individual SIR calculated, is always going to fall within that confidence interval. So I think some folks get confused saying, well, the interval includes my SIR, so is that not significant? Well, that's not what we're looking for. Your SIR will be included in those bounds. What we're looking to see is if we cross the line, try and connect the lower bound with the upper bound, does that line cross over a boundary of 1? So with these first 2 lines here, these do cross over this threshold of 1 down the middle. So these are not statistically significant. But the bottom 2 are. This first green one here, both the lower and the upper bound are greater than 1. And on the last one here, both of them are less than 1. So those are indicating statistical significance. All right, I've already mentioned that the SIR is a summary measure. And I've also alluded to the fact that we can calculate this at various levels. So I've already shown you that we have a county SIR for all of the ICUs combined. And we have one SSI, or you could get, let's say, an SSI SIR for all inpatient procedures. Let's take that at a different level. Or you could calculate a CDI SIR for all facilities in your state. So it's scalable, it can be summarized, it's risk adjusted, and it can really aid in the times when you're asked to provide one number to explain your county experience for your hospital or your SSI experience for your hospital. You don't have to worry about producing a bunch of risk stratified rates, and you don't have to worry about masking something by providing an overall cumulative rate that is not risk adjusted. So I promised you a few bullets about the SIRs that you can provide as a refresher to folks who may need that extra reminder about what it is. So you could say the SIR is a summary measure that compares the number of events of a given type observed or identified in our facility with the number that are expected or predicted of that type. The number of expected is calculated based on the types of data we have reported and the NHSN baseline data. So that's really important. So when you're reporting out SIRs for a device-associated infection, if you have a burn ICU and you've got a trauma ICU, that high level and high risk patient population is taken into account when we calculate this. The SIR does use past data, also known as the baseline, in order to predict future incidents, and it is scalable and can be easier to interpret when assessing the incidence of these HAIs at your hospital. So now that we've gone about the high-level summary of our SIR, now let's start to get into some of the numbers and work with some of those numbers. So let's say that you received a preview report from your state health department with your hospital's 2013 county SIR, which is inclusive of your 4 ICUs. These are the same ICUs we talked about this morning. You will be discussing this preview report with your committee. And before you present to the committee, you want to understand unit level data from each ICU and how the SIR is being compared to national data. So here we come. We have our first question, our voting question for the afternoon. All right, your overall county SIR is 0.962. How would this be interpreted? You observed more infections than expected. You observed a 4% higher rate than the national rate. You observed fewer infections than expected, or you observed a 4% lower rate than the national rate. Okay. It's a voting question, and 10 seconds. All right. Let's see what you guys had to say. So, 80% of you said the answer was number 3. You observed fewer infections than expected. 19 of you said number 4, that you observed a 4% lower rate than the national rate. The answer is actually number 3. And why is that? Well, you could certainly say that your facility observed a lower rate, but we can't say it's a 4% lower rate, because what we're actually comparing here are the number of infections, not the rates. This is not a ratio of the rates, it's rather a ratio of what you observe versus what we would predict for you. So you could also say you observed 4% fewer infections than expected. That's okay. But you can't say your rate was 4% lower. All right, as I've mentioned, NHSN will calculate SIRs for you. Many of you are probably already familiar with this, especially if you've been using the CMS reports for the acute care hospitals. So the main one that we're going to focus on today is not necessarily the CMS report. What we're going to focus on is an option called SIR All-Cow Data or All-County Data. So this is our output from NHSN. This is, when you run an SIR, it will include multiple tables. And what we try to do is we provide one overall table and then we try and break it down gradually. So the table after this would say, here's your SIRs for all of your critical care units versus all of your specialty care or oncology units. Then we would break it down by each CDC location type. So you'd have an SIR for all of your medical ICUs combined, let's say, if you had more than one. And then we break it down further to say, here's your SIR for each individual unit for which you've reported data. So what I want to point out here are the notes at the top of the table and the footnotes at the bottom of the table before we move on. So one of the things I want to point out is that I did limit this time period for this SIR. It says summary YR 2013 to 2013. So that was a limitation I made on the modification screen. But I also limited to the 4 ICUs already. So I had to do this work in order to make sure I only had ICUs for our sample data at CDC. If you're only reporting ICU level data to NHSN, then you wouldn't have to worry about doing this. But I decided to because I wanted to get an SIR only for my ICUs. Then, of course, we have the data in the table, but below that, we have some footnotes. There are some really important points here. The first one is that if the infection count is less than you reported, aggregate data are not available to calculate the NUM-EXPECT. Or NUM-EXP. Well, what does that mean? So we can only include those locations in the SIR for which we had a pooled mean in the published baseline report. One of the most frequently asked locations we get is telemetry units. A lot of folks are reporting for telemetry units. We did not even have a telemetry ward location type in NHSN at the time the baseline data were reported to us. It was a location that was added, I believe, in 2010. So because we don't have anything for the baseline data, we can't include that location in our SIRs. And so one of the options you could do is you could actually make internal comparison of the rates for your telemetry wards, and we will talk about that tomorrow. But just, keep that in mind. We will also provide a table at the bottom of locations that are excluded. So if you're noticing a telemetry ward is missing from your SIRs, that is why. It's for CLABSI and county. We also say that the lower bound of a 95% confidence interval is only calculated if the infection count is greater than 0. And that's because the lower bound cannot be less than 0. You can't have an SIR that is less than 0. So we actually set that to missing. So if we had 0 infections here, this 0.630 would actually look like just a period, and then we would have our upper bound. And so we could assume that it would be 0, but statistically, we just don't have a number that's produced. Also, we have a note here that says SIR values are only calculated if the number expected is greater than or equal to 1. So that means this column here in yellow, this number expected, if you're looking at individual locations or perhaps you have a small hospital, you have low number of catheter days, we're only going to calculate the SIR if that number expected is 1 or greater. And that is done in order to help enforce precision on this SIR calculation and also to help with the interpretation. Because let's think about it this way. Let's say your hospital, we calculated a number expected of 0.5, okay? And let's say you identified 2 infections. So you identified 2 infections. If we calculated the SIR, what would it be? 4. So how do you interpret that? We had 4 times more infections than predicted, but we only had 2 infections. Also, we don't have very much confidence or precision on that SAR because what it's trying to get at is you had such low exposure that we can't even predict that 1 infection would occur. Also, I want to mention, it doesn't just get at the number of device days and it being low. It also could mean that you're performing the surveillance in a location that may have a low rate of infections. Certainly we see this with CLABSI. So we may have some CLABSI rates in the baseline report where the rate is 1.1 or 1.0. And if you're reporting for that location and you look at that location's SAR, you have to have 1,000 device days before we can even calculate the number, or before we can calculate the SAR, right? Because that's getting at, we would expect 1 infection for 1,000 device days. So we get this question a lot about why isn't my SAR calculated? We're actually looking at the number expected here, the denominator. And also, of course, again, we have the source of aggregate data and the date that data sets were last generated. I just have to reiterate that because it's common questions that we get. So I think that'll help you guys a lot if you keep that in mind. So we're going to start interpreting this much like we did for the rate table. So we're going to go through the numbers. We're going to go through the motions first. So we can say during this time period, 24 counties in about 11,000 catheter days were identified. And based on national baseline data, 24.96 were expected or predicted. And then when you divide the number of counties identified by the number expected, we get an SIR of 0.962, indicating that we observed approximately 4% fewer infections than expected. So this is just a review. We talked about the p-value this morning. If you're in a bit of a food coma, I just wanted to remind of what it is. It is a probability, of course, and just like we did this morning, we're going to use a cut point of 0.05. So if a p-value is less than 0.05, we would say that we see is significantly, or our SIR is significantly different. Again, we include this p-value with your output, and what is actually being compared? So before, what we were doing is we were comparing your hospital's rate to the NHSN pooled mean. Well, what we're doing with the SIR is we're saying, is your SIR of 0.962 any different than a value of 1, where 1 means that you observed exactly what was predicted, okay? So, as a review, based on our p-value, is the number of observed infections statistically significantly different from the number expected? Yes, no, or not sure? I've got the timer going. 5 seconds. All right, let's see how you guys did. All right, 95% said no, and you would be correct because the p-value is greater than 0.05. It's actually really high. And to be honest, is it that surprising? Because you have an SIR of 0.96 and we're saying, is this any different from 1? So given the volume of data you have, it's not surprising that we're not seeing it any different. Now, I will just add here, as I'm looking at this, that if we were to multiply everything by 10, so let's say we observed 240 infections and we expected 249, our SIR would be the same, but we're probably more than likely, we're going to see a significant difference. It's because the volume of data is much greater. We have more precision because we had more exposure to that. So I just bring that up because, we have our national SIR report that's coming out. And so we may have an SIR of 0.98. And we're saying that's significantly different, even though it's just below 1, but we have so much data and so much volume that we have a lot of precision and we have a lot of confidence that we can say, statistically, this is different. Okay. So let's look at the 95% confidence interval now. So based on this confidence interval, is the number of observed infections statistically significantly different from what we would expect? Yes, no, or not sure? Ten seconds. All right, let's see how you guys did. Great, 93% of you said no, and you are correct. Now, notice that we came to the same conclusion here as we did with the p-value. And in the majority of cases, that will be in alignment. Now, we have heard from our partners at state health departments and QIOs who have been looking at this data, and they're like, we see sometimes that the p-value is less than 0.05, but the confidence interval includes 1, and they have differing results. We have recently updated our statistical methods for calculating this information, and so it's more likely they're going to be in alignment. So it should be really rare that you would find differing conclusions with the p-value and 95% confidence interval. Also, I just wanted to graph this out again. So if we're looking at our 95% confidence interval and trying to draw it out, we have 0.63, 1.409, and then when we cross, connect those two, they do go over the boundary of 1, or that threshold. All right. So when we interpret these data, we've already gone through the first 3 bullets, and so now that we've interpreted that, we can also go on to say, based on statistical evidence, we can conclude that our SIR is no different than 1. Or you could say, based on statistical evidence, we did not observe any fewer infections than what would be predicted. Okay, I've already mentioned that the number of expected events, if it's less than 1, the SIR is not calculated. And we've pretty much covered this. However, we get questions from folks about, well, then what do I do? And, we realize that we do have, quite a few small hospitals now reporting data, or hospitals that just have low volume of these device days. And they're saying, well, I can't get an SIR, so what am I supposed to do? Well, we're going to talk about this tomorrow. Of course, you can always rely on rates, but I do want to, definitely spend some time on some solutions and some options for those who continuously run into this. Because one answer is you could just group your time periods together. So if you're not getting an SIR for 1 quarter, well, then maybe try to produce it for 2 quarters combined or for the entire year. However, when you have to wait an entire year to calculate your SIR, it's not necessarily timely. So, you could use this in combination with other data reports. So we're going to start to build just some notes for our meeting. So let's say we've already included a high-level summary of our SIR. So we could take that table and summarize it into 1 bullet and say, the county SIR for the ICUs for calendar year 2013 indicates we observed about 4% fewer infections than what would be predicted for our facility, and our experience is no different than the national baseline based on statistical evidence. So it is a bit wordy, but it's 1 bullet. So it's just one example of how you could interpret or summarize the data in those table, or in that table. So I already kind of mentioned to you that when we provide SIR reports in NHSN, that we provide multiple tables. So it's not just the overall table. We provide some granular level detail for the location level SIRs. So, we urge you to take a look at these location-specific data, just like you would if you were looking at your rate tables, where you're looking at each location individually. So looking at these SIRs individually, you can look at the contribution of each location to the overall SIR. And what I mean is you could look at, okay, well, where are most of our infections coming from? Where's, our denominator for the SIR is number of expected. So where's that coming from? Where's the bulk of it coming from? Do we have any locations that have higher number of urinary catheter days, that are higher risk locations, that are maybe contributing the most to that overall SIR for our facility? This table also allows you to see if there are any months or locations missing from the overall SIR. So what I want to point out here is that our med-surg ICU, this third row, notice that there's an 11 in the months column. So this is supposed to be SIRs for my entire calendar year. So I should have 12 months of data. If all of these units were open and I was performing surveillance for Cowdy in every one of these locations, I would expect that I would have 12 months of data here, but I only have 11. So that's a clue into me that, I am missing a month of data. I've got to figure out what's going on. Hopefully, if it was a month missing from earlier in that 2013, you would have already picked up on it if you're looking at your data at a more regular time period. But let's say you forgot to enter December's data for that location. That can clue you in. So, based on the information in this table, which location's data are you most concerned about? It's a voting question. I'm interested to see what you guys have to say about this. The one is the cardiothoracic ICU, 2 the MICU, 3 the MS ICU, or 4 the surgical ICU. So you can begin voting. I see a lot of you are already voting. Okay, 8 seconds left. Okay, so let's see what you guys said. And there could be more than one right answer. Okay, so 86% of you said the cardiothoracic ICU and 14% said the med-surg ICU. Is that right? Yeah, the med-surg ICU. So what did I say? Well, I said the cardiothoracic ICU. Truth be told, you might actually be concerned about all of them. Even though you have SIRs that are below 1, you may be saying, it's not quite good enough. I thought they should be lower given the prevention efforts that we've been implementing in our hospital. So I said the the cardiothoracic ICU because while both the p-value and confidence interval say that we're no different than 1, I still have an SIR that is the highest in this group of 4, and it is over 1. It is the only one that's greater than 1. So clearly, I need to look at this and be like, okay, let's see what's going on here. Let's dig a little bit further. Is there something I need to be aware of? Did something change over the year? And you may actually want to look at the SIRs for this location. Maybe you want to look at it by quarter. Maybe you want to look at the monthly rates, revisit those data and see, okay, is this consistent over the year, or have we had like an increase or a spike during one part of the year that's happening now? Like maybe it was at the very end of the year and we need to address this. So we're going to build on our notes for the meeting. We've already gone over the wordy one bullet sentence. But we can add to that and say that we looked at the county SIRs for each ICU for that same time period and noticed that all of them had SIRs less than 1 except for our cardiothoracic ICU. This location observed approximately 40% more infections than predicted. So this is an area where we kind of get into the fact that while there was no statistical evidence that it was different, there's some practical significance in this. And there's room for more prevention, potentially, I would say. Now, all of that SIR talk was about counties. And I just want to let you know that SIRs for CLABSI are actually calculated using the same sort of methodology as county. Okay, we already talked about the number of expected being the number of device days times the pooled mean over 1,000. So we would just use that for CLABSI. It's just that they have a different baseline period, and that's in that table that I referred you to this morning. And of course, we have options to run the SIRs using either in-plan CLABSI data or all CLABSI data, and we do have that for CMS reporting. All right, so to sum up this first day of analysis training, I hope that after this first day, you're realizing that analyzing the data can really help you own your data. It gives you the power to own your data and to speak to it and to help you tell a story as to what's going on. I mean, certainly, this was just one example hospital that, this is a fake hospital, right? But you, in your own hospital, you know what's been going on. You've been doing all this surveillance. You know if there's specific efforts taking place in specific units. And so you can really use that to help support the data that you're presenting. Of course, we have various output options and reports that you can use, you can modify to meet your needs. And obtaining rates and device utilization ratios in SIRs can really help you assess how your facility compares to, I said the latest NHSN pooled means, but we know that's not true for SIRs at this point. But, it can help you see how you compare to national data. So I have left quite a bit of time, quite a bit of time for questions. So if there's people in the room who have questions, please feel free to step up to the mic. Oh, hold on. We're gonna get the mics turned on. Hold on one second. We want to make sure that people on the webcast can hear the questions. Okay.
Karen Singson from Provo, Utah. Explain to us the relationship between the SIR data and how that plays with value-based purchasing.
That is a great question and one I do not have an answer to. I'm certainly not an expert in value-based purchasing, and I think our colleagues at CMS are definitely better suited to answer that question. I'm not aware of the algorithms and the work done to calculate that. So I apologize. I have to say I don't know. Exactly. Go ahead.
My name is Luke. I'm from West Virginia Healthcare Authority, and I have a couple of questions. Pretty much same thing. Who does the data quality checks on whatever is submitted into the NHSN surveillance system? Who does the quality checks? Is it the CMS or is it the hospitals? And also, who does the validation? Is it does the CMS hire a third consulting company or the State Healthcare Authority?
Sure. So those are excellent questions. With regard to data quality checking, we have a lot of rules in NHSN that do the data quality checking for us, and some of you may have run into errors because of those data quality checks, because we're trying to make sure in many cases, for the cases that we can think of that we're in absolute certainty we can prevent from coming into the system. We haven't prevented all of them, and at CDC we do a lot of data quality checking when we do our regular reports. So you may hear from us from time to time, and we'll talk about some data quality checks specific to C. diff tomorrow. There is a level that happens at CDC. there's also the hope that at the hospital you would pick up on some things that you may think are inaccurate when you're looking at your data. And some state health departments also do some data quality checking and some QIOs, and we've certainly had communications from them, and they help us prevent those from happening. With regard to validation, some validation has been performed by state health departments. There is a level of validation done by CMS. Again, I'm not the best person to speak to CMS related validation. So, you know, that is performed. They have their process that they work with that. So I'm just going to leave it at that. I'm going to take your question.
Great. My name's Tina Schween. I'm with Qualis Health, QIO, that serves Washington and Idaho. And my question is, CDC provides CMS with reports that are in those advanced folders.
Yep.
They provide SIRs to CMS that they put up on Hospital Compare.
Mm-hmm.
I believe that's the source of where they get that information.
Right.
Could you remind me, is the method for the SIR for CAUTI and CLABSI the same as the summary one you showed us?
Okay, so that's an excellent question.
Because
so,
that's to feedback to the VBP question.
Mm-hmm.
I mean, they are using what you send them to
Right.
go into VBP. The point assignment happens after that, but
right.
that's a good thing to know.
Yeah, so that's a great question. So the SIRs that we provide to CMS on your behalf follow the exact same methods that I talked about here. It's just that there's SIRs for a specific time period. They want it quarterly, so we submit quarterly SIRs. And it's only ICU level data right now for acute care hospitals for CLABSI and CAUTI. But the same baseline data are used, the same methods are used. So let me go back, to my slide. I don't know if it's going to open up. It's not opening up. But the slide I had that had the overall SIR for 4 ICUs, let's say that was broken up by quarter. I should get the same SIR in that CMS report in NHSN. It's the same data being used. It's just we try to provide and input different limitations like running it by quarter so that it's much easier on you all, so that you can just click run without having to do very much modification at all and see what we will submit to CMS on the next quarterly submission. So that's a good question. We'll go to you.
My name is Bill Cecil. I'm from the Tennessee Hospital Association Hospital Engagement Network.
Hi.
And one of the things that CMS requires us to do is to calculate improvement associated with prevention efforts.
Mm-hmm.
And I'd like to give you a scenario and just ask you what you think of it.
Okay.
Talking about CAUTI, suppose you had 10,000 catheter days and 100 CAUTIs, and after a lot of work, a couple of years of time, you've been able to reduce catheter days to 1,000.
Mm-hmm.
And
Wow. Okay.
the number of CAUTIs proportionately. The
So
SIR
by
is,
10. So okay.
so the SIR, the standardized infection ratio is still 1.
Okay.
Has there been any improvement? I mean, you've reduced the number of CAUTIs by 90.
Right. Right. I think that's a really, really good point. It's something that we also get questions about, knowing that, there's a big push, obviously, to cut down on the device use and time for CAUTIs specifically. I guess what I would say is that you could look at that as seeing how many have, like in raw numbers, how many infections have we actually reduced, right? So you had 100 CAUTIs and now you have, what, 10?
10.
Let's say. So 90 CAUTIs, you could say, were prevented potentially by your efforts. And that is one way that you could interpret those data. Even though your SIR is still 1, you still seen this reduction in the number that occurred.
And unfortunately, they require that we use the SIR to calculate
Right.
the improvement.
Yeah.
But thank
Yeah.
you.
Uh-huh.
Hi, I'm Ginger Fuller-Franks, and I work for the Idaho Hospital Association. So I do HIN, and I'm also the representative. I work for the State Health Department on the NHSN project. So 2 things. The first is we have a lot of critical access hospitals or hospitals with very few procedures, so the SIR won't calculate for them. And I went in and the highest I could get it to calculate for was 1 year.
Yeah.
Still couldn't get it anywhere. Do you have any suggestions? Because they're asking me, what do we tell our surgeons?
Sure.
What do we tell our CEO?
Sure. So, one way is to, I know that's tough when you've got SSIs, of course. If they have that low number of procedures actually performed, they may want to consider a rate, or they may just want to look at, how many actually are, what is coming up quarterly for expected? Is it 0.25? And if they have one SSI, 2 SSIs, they may want to take a look at that. But if it's 0, then, celebrate the 0. I think that, it's easy to get stuck into the thought that all that matters are these sophisticated statistics, but that's not the case all the time. However, I would say that, we're always discussing internally at CDC, we need to look at these critical access hospitals and low volumes, and what are some other measures that we could provide that would be more appropriate for that setting.
Right. The other question I have is, you talked about the CAUTI and the CLABSI values provided to CMS for the CMS SIR, but it's my understanding that that's not the way it works for surgical site, that they're just looking at ASA and age, and I'm not quite sure what all.
Right. So tomorrow we'll talk about, there's a different risk model for CMS reported SSI data.
Okay.
Yeah.
Okay.
Yep.
Thank you.
All right. Who's next?
Can I just jump in quickly, because it's kind of in response to that question?
Okay.
The other method you could use would certainly be the SAR calculator, which exists in the stats area. So do you want to tell them about that and how they could do that?
The statistics calculator will actually not provide an SIR if it's less than 1 expected.
So they won't do that anymore?
No.
That was considered an upgrade?
We updated. No, it's a matter to be consistent. So if it was calculated before, it was an error. But regardless, remember, the volume of the volume of data is going to be so low, you're not going to see any statistical significance.
Actually, if the number of observed is 0, but you expected 100, certainly in that case you can't calculate significance.
Right. Absolutely. It's just when the number of expected is less than 1. Can you come up to the mic, please? I'm sorry. I just want to make sure the people on web streaming can hear.
So what I was saying was, if you had 100 infections, but you had 0 expected, or 0.1 expected,
right,
certainly in that case you would want to be able to show that that was significantly more.
Sure.
And that was one of the advantages of the SAR calculator as it previously existed.
Right. And, I apologize. I believe that was probably an error that we did that, because we want to be consistent. So when we updated our statistical methods, that was updated in line with that.
Thanks. Maggie, great job. Always great to hear you go through the analysis. To maybe add something that the gentleman from Tennessee had just asked you about, and I like how you put the positive twist on the reduction of the raw numbers. But,
right.
We had the same conversation at lunch, so I think I can recite what we came up with. And that's if you're a patient receiving a catheter still after that improvement or that reduction, the risk of having a CAUTI is still the same.
Yeah, no, I mean, I think it's a good point. I mean, there's many ways to be looking at this, and we've certainly had discussions with some of our IPs, our actual users, who have said, well, we're reducing our catheter days, but our SIR isn't going anywhere, our denominator's smaller, our SIR is still high, but they still had the same number of CAUTIs reported. So that hadn't changed as well. So, I mean, I think there's multiple ways to be looking.
It's kind of an inverse metric when the denominator decreases like that. And I know the #1 preventive measure for the CUS project is reducing catheter days.
Yeah.
Removal.
Sure.
I wanted to mention something that may help. It's probably not the first time you've heard this, but when you run the CMS SIR reports and you move into the modify section of that,
yep,
the default at the bottom left is to group by by quarter instead of by month.
Right.
And I know you're providing CMS and their subcontractor provides reports to the QIOs that are all quarterly. And we see in our group that hospitals come off the list because they have submitted data in that quarter. And if they've got multiple ICUs and do one ICU in only 1 month out of the quarter,
Right.
then they've met the requirements of CMS. And I have a feeling it's affecting, your national database.
Right. No, and that's a really good point. We certainly appreciate the work that's been done by our partners and state health departments and QIOs who do start to look at the monthly data and let the facilities know, hey, your quarterly data are submitted, but they're not actually complete.
And for hospitals that are running that to look at their own data, if that default could just be set to month instead of quarter, I don't know if that's possible.
Well, okay, so good question. So the reason we did the quarter for CMS, for the CMS SIRs, is because we wanted it to be very easy. So you could click run and see exactly.
Oh, okay.
The other SIRs, the non-CMS SIRs, actually run by half year. 6-month time period. And the reasoning for that was because you've got more volume of data and we can be more precise about what we're providing. But we encourage folks to be looking at these data on a monthly basis, even in addition with their rates. So, yep.
So now that we understand, I'm Melissa Morgan from Cone Health in Greensboro, North Carolina. And now that we understand SIRs, does NHSN have any recommendations for how to present that? Because now everybody wants it in a graph or a bar graph and comparing each hospital. So what are your recommendations for presentation?
So you're looking at like recommendations for graphically presenting those data.
And my surgeons actually request some kind of combination graph with a rate, which I cannot figure out how to do.
Yeah.
So,
I think that's something we could certainly discuss internally at CDC is looking, can we start to provide a graphical representation of SIRs for folks? But I know I have helped a few people with producing these in Excel. If you export your SIRs, you can use something called a stock chart option that will allow you to plot your SIR with the confidence interval bounds on it.
Okay.
So I'm not an Excel expert. I know it pretty well, but if you look through the Excel help or go through Google and just look for stock chart options. Also, if you have questions, you can contact us. I do have a document that I found online that is pretty helpful. Okay, I think we've got time for questions.
It's a quick question.
Yeah.
Are you investigating other types of risk factors outside just population-based for units? Essentially, that's the only risk factor we have for CLABSI and CAUTI, right?
Right. So we can only do risk adjustment on the data that we have. And for device-associated infections, we don't have a lot of patient-level information that we can risk adjust in denominator data. We have summarized monthly data, and we also have facility-level data. However, as we start talking about the new baseline time period and preparing for that, we will be looking at other ways. Is there a different way that we need to provide risk adjustment for, let's say, CLABSI and CAUTI that would be better suited than what we're currently providing? So those discussions are, they're in progress. We're getting there, and stay tuned about that, I guess. Go ahead.
Hi, I'm Cindy Prosnack with the Georgia QIO, and just to echo what the gentleman there was saying about the number of months in the CMS reports, when you run those reports from your hospital, you will see either 3 months, 2 months, or 1 month in a quarter. If you see less than 3 months in a quarter, you know that your data is incomplete.
Yes.
So that's the best way to look at that.
Yes, thank you for that.
And also, I know you're going to get into this tomorrow, but I've had questions from a good many of our hospitals on the surgical site infection data, and if there is going to be any way of putting data into NHSN without having to put every single procedure into it.
Right. So we're not there yet. And the risk adjustment methods, of course, require all of that detailed information from every single procedure record. So Yeah, we're not at that point. But thank you. Excellent question. All right. So thank you all for your attention. And I think we can go ahead and turn it over to Angela.